We're going.
Okay. Good evening, everybody. Welcome. Good to see you all again, many of you. And it's a great joy to welcome Dr. Amy Case to talk to us about palliative care and making those decisions that need to be made physically at the end of life. We've talked about the legal aspect, we've talked about the financial aspect, and now we're going to talk a little bit about what happens to your body. But first, I'd like to offer this prayer, a prayer for doctors and nurses. I think they don't get enough prayer, probably. So let us pray. Sanctify, O Lord, those whom you have called to the study and practice of the arts of healing and to the prevention of disease and pain. Strengthen them by your life-giving spirit, that by their ministries the health of the community may be promoted and your creation glorified through Jesus Christ our Lord. Amen. Dr. Case.
All right, well, thank you all for inviting me. I had 7 patients on my clinic schedule today, and I was at Roswell in full swing, and I feel like I talk about this stuff pretty much every day. This is my job. So for those of you who don't know me, I probably see most of you in church every Sunday. I work at Roswell Park. I'm an internist. I've been practicing 20 years. I look younger than I am. I'm almost 50. I have 5 kids who we are parishioners here, know most of you. Internist and a specialty in something called palliative medicine, which some people may not know what that is, but it's kind of a field of medicine that focuses on quality of life, especially for people who are having complex illness or serious disease. It can be cancer. In my case, I take care of cancer patients at Roswell Park. And then, other people in my field work, prior to this, I worked at the VA, and I dealt with people who had like emphysema, COPD, it can be cardiac disease, end-stage cardiac disease. It can be a whole host of dementia, diseases that can eventually cause people to, nearing the end of their life. And so the trajectory, generally palliative medicine can be provided anywhere in the trajectory of an illness. Even at the beginning of a diagnosis, we can get involved, especially if there's a lot of complex psychosocial concerns or family concerns, or we see a lot of folks with comorbid. Comorbid means that there's a secondary thing going on, that can make the case more complex. So addiction, or we see a lot of folks who have financial hardships, addiction. It's pretty rough out there. So mental illness. Can you hear me? Do you? Oh.
The microphone is actually for the Zoom.
Can the person on Zoom hear me?
Yeah, they can hear you.
Okay.
I'm good.
Is anyone here in the health field or has had a health background at all? Or? Yeah, so I've dedicated my life to this mission. I feel like it's a vocation, it's a passion. I have started and ran programs, I have hired people, I've built teams, and that type of leadership in this space is very, very important to me. Started and ran the fellowship and trained many doctors who, many of which have gone on to work in other places. In Buffalo, for example, hospice. Many of the doctors who work there, I started the training program back in 2005, where a lot of those doctors trained, and now they work at hospice, and they're my colleagues and juniors, really. And Chris Curran, I don't know if anyone knows him, but he's the CEO of hospice. Him and I are very close in age and actually very much kind of contemporaries, and we've known each other for many years, and we collaborate a lot. So Roswell Park collaborates with Buffalo Hospice, Niagara Hospice, and the work I do. So I'm also a hospice doctor, so I do home visits when I can, and I do hospice work as well. So there's a trajectory. So we get involved sometimes early, sometimes kind of midway through how things are going, especially if people are getting chemotherapy or starting to have side effects, and we try to help them with some of their symptoms. And then at the end of life, when people are really struggling with what do we do as the cancer or the disease is worsening. And palliative medicine, the focus of that is on the whole person, and it is the physical, emotional, and spiritual, actually. So in order to call something, in order to say that you're providing a patient and family, because we treat the family unit. So in order to provide the family and the patient with palliative medicine, you have to mandatorily be a team, not just a physician, not just a nurse practitioner, not just a nurse by themselves. It has to be a team addressing the physical, the emotional, the spiritual. So on our team, we've recruited and we continue to enrich all the disciplines of medicine. That's me. We have nurses. I have 7 doctors on our team we've recruited over the years. So we've built a pretty large team. So 7 doctors, multiple nurses. We have social workers, psychologists, psychiatrists. We work a lot with PT, OT, physical therapy, occupational therapy. We have child life. So that specialty focuses on children of especially young patients who are sick. So they provide educational materials for children. We sometimes get pediatric patients who are themselves ill and are the patients. And so I do take care of children. And then you're trying to palliate the parents too, which is really tricky. A lot of our patients are quite elderly, quite frail. Many of them, like I said, have addiction and mental illness. So I'm very much interested in helping those. I always say the sicker they are, the more complicated they are, the more difficult they are, bring it on. Like, I love those cases. I want difficult cases. Whereas some of my colleagues are like, oh, I can't deal with this. They're on cocaine or whatever. And I'm like, bring them over here. We're going to give them a hug. We're going to give them the palliative hug. And that's really what we call it, is wraparound care. We spend about an hour with new people when we see them for the first time. And people are like, where has this been my entire life? Like, I've been here at Roswell for X amount of years. How come this is only being given to me just now? And so we are a service that's a support service, meaning that we have to be called in or requested by the primary care oncology teams. If a patient wants this service, they can request it. And we can get involved if the family or patient is requesting that. And we often do get family or patient requests. The oncology teams at Roswell, though, we've built a lot of trust and collaboration between our oncology teams. So pretty much every team at Roswell, from pediatrics to lymphoma to leukemia to solid tumor, they all call us now. When I first started I think I've been there 8 years now. When I first started, there were certain cancer types, they didn't call us. They didn't want anything to do with us. They thought we were going to come in and just stop treatment and talk about do not resuscitate and give up on the patient. And over time, we've kind of built some trust with the teams at Roswell, and they know that when we get called in, we're very kind of collaborative. We try to meet them where they're at. So that's kind of my background. That's what I do. And there's something called a death cafe. I don't know if you've ever heard of that, but this is what it reminded me of when you called me here today to ask me. It's called, it's a provocative, it's called a death cafe. It's a provocative term. But that's what this is actually. I mean, we're breaking, we're having little snacks and coffee, and we're here gathered today to talk about death. And so a death cafe is something that I've actually been part of. I've run them, I've facilitated them. It's a very provocative thing that is done in this space where it is welcomed by groups of people where they're curious about it, they want to learn more. And I guess I consider myself an expert in this area. So I'm here and I'm going to try to talk less and listen more, but I'm going to start by asking you all, and I know some of your names, and if I apologize if I know all your names, but please remind me your name, and then we can get to know you a little bit more. But how do we feel about when I bring up the word death? I mean, that word probably brings up some emotion, stirs up some emotion. We all have our personal experiences probably with it at this age that you are. You probably have lost someone close to you, and what has that been like? And what if I were to give you a piece of paper and some markers or crayons, and you could draw a picture of what you think that your end-of-life situation would look like in a picture? And if you have paper and pen and you want to draw it, go ahead. I didn't bring papers and pens, but I did bring some other things I'm going to go over. If you wanted to draw that on a piece of paper or in your mind, think about that for a few minutes, and let's just reflect on what would that look like for me? Where would I want to be? What would I want to be doing? If I had, we usually say if time was short, because I don't want to quantify what that time is short means, but usually for people that I'm having these discussions with, it's months or weeks. If time is short, where would you want to be? What do you want to be doing? And who do you want to be spending time with? So I'll just give you a few minutes to think about it, and then I would like to open it up for all of you to kind of just freely chime in and just talk about it. I'm going to invite you to do that if you feel comfortable.
Well,
Remind me your first name.
I'm Deck James, shaken, not stirred. 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 Not stir I envision it down the road. I am, as society says, I am in my twilight years, and some of my friends might think I'm in the twilight zone. But moving along, I guess it would be like a light at the end of the tunnel. I would like to hear my family around me. I hope I don't have to suffer too much. And I'm betting that good Lord will meet me at the end of the tunnel.
That was beautiful. Thank you for sharing that. I was kind of hoping this group might, I was assuming this group might be pretty accepting and well adjusted to the other side, I guess we'd say. But, you know, sometimes, even though we have faith, you know, there is fear of what the unknown is and what that would look like. And sometimes our loved ones may have had an experience that isn't so great. Does anyone have anything else they want to say about? So you envision it to be peaceful. I assume that means that you'd want to be in your home or surrounded by the people you love.
Yes.
In the American society, death is actually quite different often than that. Because if we don't plan ahead, a lot of times what happens is if someone becomes ill and the family doesn't have the resources to know what to do for that, to care for that person in the home, they'll call 911 and then, you know, ambulances are, you know, dispatched, and then the can of worms is kind of opened, and then people can end up on, you know, treatments that may or may not agree with, in line with what their values are. And so when I meet people, the first thing I try to do, which is hard to do with this group, is to get to know people as who they are, like what's important to you, what are the things you like to do. But the common themes that I hear from my patients is they want to spend time with their families. They often want to be in their homes, if that's possible. Some people don't want to be in their homes. I had some young patients who said, I don't want to die in my home, because if I did, my children, who are in their teens, you know, would be in this home, living in it. And I'd worry that it would make them uncomfortable to be in a home where I died. And so when they bring forward those concerns and fears, we talk about it. You know, what are your concerns? And what do you think death is like? Because they often feel that it's very scary or terrible, or that there's going to be screaming and pain. And actually, it doesn't have to be that way at all. It can be quite peaceful and quite beautiful. And having children be around that is actually not a terrible thing always. Sometimes it's good for them. So we talk to them about what that would like, how we can help them have that be as peaceful as possible, and what type of planning do we need to do in advance, with whom and how and when, you know, to make sure that when that time does come, that it's kind of like as smooth as possible, I guess you'd say. I agree with you. I hope there's a light, and I hope that I see those people that died that I miss, and that you get welcomed, and I hope that that's that, like that.
I've only experienced 2 people so far in my life that I saw them just before they died, a day or 2. And I was really amazed how at peace they were. And it was like they didn't, so they were in hospice. And it was like, hi, you know, how are you, you know, and just talking. And that brought me a lot of comfort, because I think everybody worries about if it's going to be a painful death, however they, you know, die. And that Roger and I moved from a big house, because it was our first house together. And I said to him, I don't want to be the one to have to close the door. And that, so we moved to a ranch home, and it's a house that we have planned for this. We really have planned for our future years, and it's a house that either one of us can manage to live in, and things like that. So, but I do believe I see my body as a host, and I can feel the difference between my body and my spirit. And I just believe that the spirit is inside this shell, and living, and
We'll love on.
facing every day's challenge or whatever. So I do believe there is a separation. and that, and I believe that there's a heaven.
And I think that spirituality, when I ask people what is important to them, like what is it that brings you joy? What is it that gets you up in the morning? And what brings you strength are the questions I often ask my patients when they're very fearful, sad, grieving. I'll ask them, what has gotten you through before? And I would say most of the people say family, friends, and then their faith, their spirituality.
Yeah.
That gets them through, their prayer. And, you know, that's why palliative care cannot be called palliative care unless you have a medical, emotional, and a spiritual expert taking care of that patient as a unit. So the spiritual people at Roswell are in my department. I'm the chair of a department there, and spiritual care is housed in our department. And what better place to house those professionals? Because then they can come and then they can pray with the patients. It's all religions, whether you're Christian, Jewish, Muslim. So, we often call in the spiritual folks. When folks are grieving, though, often there's a questioning of faith that can occur, and people get quite, scared, anxious about what is to come. And sometimes the spiritual care chaplains can really work with them and figure some of that out. Or we'll call in the community spiritual care people they've known for many years to help. But, sometimes in the time of right before someone's going to leave this earth, when you're in that position, it's easy to say when you're healthy, that you have this strong faith. And I often see the faith is challenged, and people get very despondent.
Yeah.
And there's a lot of emotional and existential suffering, not just physical. And so when I say the word existential, you guys all know what I mean. Like, why is this happening to me? Like, why me? And so it's easier for us to say when we're healthy, like I have my faith and I hope that continues throughout. But when you're called, I notice that people really struggle.
Yeah.
They really struggle, and the faith and the prayer gets them through.
Yeah.
We try to remind them of, hey, remember that time that, you lost your daughter, or you had that divorce, or whatever it was, that suffering that you had. What did you do to get through that? And they'll say, oh, I did this or that, or I prayed, and and then we remind them that that was something, that's a tool that you can use to help yourself.
And by the way, my name is Barbara.
Okay.
But my daughter-in-law is a speech pathologist in the nursing home, St. Anne's in Rochester. And she wanted to work with the older population. And at first, I was like, usually there's only one way out of a nursing home, And I thought, she's so young, in her 20s, why would she? But she gets a lot of satisfaction of helping the people at that time in their life.
That's beautiful.
And it really didn't click until she had that position. You're doing something that's so important probably for our entire life. It's at the time when we need you the most, and it's...
Thank you.
It's really...
My work doesn't feel like work to me, to be honest with
Yeah.
you guys. When I'm at work,
Yeah.
I don't want to leave. I mean, when I want to leave to come home to see the kids, but I get so in the flow when I'm at work,
Yeah.
especially in clinic and when I'm seeing patients. So I could never reduce my clinical work. I'm taking on a lot of leadership stuff and extra duties, but I'm not giving up the clinical because I could not do that. That's actually what keeps me going. The administrative stuff is quite stressful. There's a lot of meetings, there's a lot of interpersonal BS.
Yeah.
But the sitting there with going to someone's home after I've met them just a couple times, who's 58 years old and has 3 children that are 18, 23 and 30, and you go to the home to take care of a woman with a big mask coming out of her neck, and she's at the end of life, and that she's perky and she's talking and joking around with you, but this is probably the last time you're going to see her, and it was. And I went into her home, and after we joked around, and I got her pain managed, and she was like, "Thank you, Dr. Case. I don't know what I would have done without you managing my pain, because I was in so much pain when I met you, and now I'm in none." And then when I got up to leave, she threw her arms around me, hugged me, kissed me, and said, "I love you." So that. And she's practically a stranger. I'd met her just twice.
Yeah.
So that type of, that's why I exist. That's why I'm here.
Yeah.
I'm with you on that. During COVID, I would get called by Absolute Care to give last rites over FaceTime. Typically, it's best if you're there in person and you have the holy oil, and all of that. But in the initial phases of COVID, we weren't allowed in. So they would call me, and I would say, "Give me 10 minutes to get my collar on," because if they woke up, I wanted them to see a priest. And so I would get called, and quite a few times I did this. And so I just changed the words in the little service that I use. So instead of saying, "I anoint you," it's the Holy Spirit anoints you, whatever. And there were times when people would indeed open their eyes and look me in the eye. This one woman, I finished the whole thing, I've been praying, and she looked like she was asleep, but she opened her eyes and she looked at me, she said, "I love you." And I thought, probably nobody's prayed with her in years.
Right.
So yeah, it was beautiful. So
It's a very intimate time.
that's the stuff I
Yeah.
love. If I can say I love, Sandy's mother was one of the most beautiful
Yes.
functions that I ever did. And she's the only one who ever actually slipped out in the middle of last rites. Like when we started, she was with us, and when we finished,
Aw.
she was gone. And I mean, she wasn't gone, but she was gone. It was beautiful. It was absolutely one of the most beautiful, one I will never, ever forget.
Right.
Yeah, I feel this bond with that family.
You experience things with families, and those families, I'll be like out in the public, because I've taken care of thousands of patients over my career and seen probably more than 1,000 deaths, unfortunately, many. But I've been out and they've been like, "Dr. Case, thank you so much for caring for my dad." And I'll like look at them, they look familiar, maybe it's 10 years ago, I don't know. Usually sometimes I can remember them, but sometimes it's hard because of the amount of people I see. But so back to the question of, what is it that you're curious about this? Do you have questions about what things are like? Do you have experiences that you want to share, views?
Sure. So yeah, Mother Ann mentioned, but my experience was with my mom, and it was with hospice, and so she had cancer in her lungs, and her biggest fear was having that drowning sensation. And your team came in, and they assured her that they would prevent that, and they did. And it was very peaceful. So that is my perception of what mine is going to be like, because I haven't seen the other side of things.
Because you've had a good experience.
And I agree, there's going to be light and things, and then I'll see the people that have passed before me, including my dogs.
Nice.
That's one thing that I plan on seeing them. And there's 2 of them that I have to apologize to.
Only 2?
Well, yes. So
Just 2.
one of the last puppies I got her name was Peaches. Many of you may have heard about her, but I took her to actual training, where I didn't train the 2 previous dogs that I had. And after the first training session, I'm like, "Oh my God, those dogs never had a chance." So yes, I have to apologize to Hazard and CR when I get there and say, "You guys were good, and you could have been so much better."
You could have been so much better.
You did the best you could.
Yeah, with no knowledge, yes.
Right.
Yeah. But no, I expect it to be peaceful and with family, and I hope that does indeed happen.
Yeah, and I think when surveyed, 95% of the American population prefers to be home, surrounded by family, have ideally be cognitively intact. I mean, that doesn't always happen, but to be able to have your mind, to be able to be comfortable and not in pain. That's what most people say.
Yeah.
But that does not correlate with what happens, unfortunately. And when I meet people and I'm on the case, Dr. Case is on the case. I reassure them, you will not die in pain. You will not suffocate if I'm on your case. Can I promise that for everyone in the whole world? No, because I haven't met those people. But if me or my team or hospice is on the case, that likely will not happen. Do people die in pain? Yes, they do. Unfortunately, some people do. Do people have confusion? Something called delirium, which is a very scary thing, and it's super common. About 75% of deaths are complicated by delirium, which is it almost seems like dementia, where the person may suddenly become really super disoriented, confused, forgetful. They may see things that aren't there. And when I deal with families that are having a family member with delirium, they need a lot of help because they're very distressed, because this is not their loved one. And I don't know if anyone's experienced a family member who's had delirium before they died, but we're pretty skilled at managing it and explaining what it is and telling you. Often we can reverse it if we get in there and try to figure out the cause, because there are multiple causes that sometimes can be reversed and other times that they can't. So for example, like if your calcium is high, we can try to treat that, and get the calcium down. But there's other things like cancer that can sometimes cause reasons to be delirious. Infections, you treat the infection. There are causes of confusion that can be reversed. If we get in there in a good enough time, we can sometimes do it. But while you're trying to reverse it, there could be pain, there could be shortness of breath. And every single person I meet, that's why it takes an hour, I go through literally every symptom with them. Are you short of breath? Are you constipated? Are you nauseous? Are you throwing up? Are you having insomnia? Are you depressed? I'm doing depression screens, I'm doing anxiety assessments. And I'm asking, the first thing I ask them is, who's important to you? Who are your people? Tell me about you, not the cancer. I don't want to hear about the cancer right now. Tell me who you are. What's important to you? What did you do for a living? What do you like to do for fun? And you'd be surprised how many people tell me, I don't have fun. What's fun? Because cancer has completely consumed their life. And so I try to remind them to what they were before the disease, And so learning about that personhood or that humanity is really just what is the key to what I do. Because I don't care about the other stuff. I care about that first. Because first you're a person. And then the disease and all that other stuff comes second. But if someone's writhing around in pain, obviously we get them comfortable immediately, like within minutes. If someone is terribly, terribly in pain, we will give injections, we will medicate, and I will promise you that I'll get that pain managed within minutes. So do people get pain? Yes, they do. They get bad pain, but we can manage it. You just got to get the right people on the case, and there could be doctors that you see that are not palliative specialists that do a great job in managing pain. You may not need a palliative specialist. And people do primary palliative care, they practice symptom management, and they do a great job. You get referred to hospice by your primary doctor, and all of that. You never meet someone like me. But with cancer pain, it can be quite complex, and so we often do have to get involved. Any other thoughts or reflections that you can share?
What's the difference between palliative care and hospice?
It's a great question. Hospice is actually an insurance benefit, a Medicare benefit that kicks in, and it pays for all of your medications and your commode and your hospital bed and your nursing care in the home. Ideally, it was set up to provide people with end-of-life care in the home, which is not a moneymaker. So if I try to start up my own business and do home care, there's no way to bill for that in the American system. Our system is a fee-for-service system, and Medicare is like a benefit that kicks in when you have less than 6 months to live, and you have to have 2 doctors certify that this patient can certify for hospice. And you have to decide at that point that you're not going to be pursuing life-saving interventions or curable intent of disease. So you have to say, I'm done with the chemo. I'm putting aside, all these crazy medications that may be kind of causing more harm than good. And it's a values conversation that is had when that person makes that decision to enroll in hospice, which you have to sign literally a form. And then 80% of the time, hospice is done in the home. And then I'd say about 10% of the time, home is not possible for certain people. They may not have caregivers, and they may prefer to die in a facility, either a nursing home or a hospice inpatient unit, which is usually reserved for the last weeks of life or for respite care, a very short-term place. You cannot live there. There are hospice houses. That is a home run by volunteers. We do have one in Buffalo called the Sloan Comfort Home. There's many in Rochester. And those homes are run by volunteers, and they're literally provide room and board for someone who's dying, but they are not, they're all voluntary. Like basically no one pays for this. The healthcare system does not pay for that. And then hospice comes into that home to provide care in that home. And then hospice can even go into a nursing home or an assisted living because that's their home. So they'll provide care in addition to what the nursing home staff is doing. Some nursing homes say they have their own hospice, which is kind of crap. And they may or may not be trained or skilled in that. So when I always educate my families that if you are searching for a nursing home, and if any of your families ever are, I would encourage you to talk to me, because I kind of know which ones are good and which ones are not good, and which ones provide good end-of-life care and which ones don't. But there are plenty of nursing homes that do an okay job. There are some that let hospice in, which are the ones I like. And there's other ones that say we do it on our own, which may or may not be good. So the ones that do it on their own, you may not want to go to that one, because you're not really guaranteed high-skill end-of-life care. And then palliative care is what I do, which is the whole trajectory of an illness is like from diagnosis to death, right? So we can meet them anytime in that diagnosis. It doesn't have to be 6 months or less. It doesn't have to be tied to an insurance plan like Medicare benefit. Anyone can have it. It can be in the home. It can be in the hospital. It can be in the clinic. Like I see people in clinic. And most of the time it's in the hospital and the clinic, whereas most of the time hospice is in the home. And most of the patients I see in palliative, if I do a decent job talking to them about their wishes and values, they eventually then transition to hospice, where if I've known them for a long time, I'll continue to follow them into their homes. And I do it after work and on the weekends because I still work a full-time job. So my home visits cannot happen during my Roswell day. So anyways, like I can't do that for everyone, which I wish I could, but special people, I'll go to their homes, which is really, really awesome when I can have that kind of continuity of care and help that person until they die. I have a gentleman right now that I literally was getting texted on who's in the midst of transitioning, and he, was someone I met in Roswell, helped them all the way through. And that was pretty rewarding. So palliative care can be provided anytime. You can bill for it from your insurance, and it's kind of like a subspecialty of any other type, like cardiology, pulmonology, GI. Palliative medicine is a subspecialty of medicine that literally specialists get trained in. We have to take boards in it, and we have fellowships. So it's a little different than hospice that way, that can be done anytime by, in any scenario. Yeah.
My first question is probably a little outside the box. Does Western New York have higher than normal rates of cancer?
Ooh, that's a good question.
In MS, I understand.
Yes, that is true. MS rate is higher, and cancer rates are pretty high here. And I think it is tied to like Love Canal and some of the other places that we've had. We've had a lot of kind of not so good things in our environment that over the years can negatively impact health. I also think that social economic status plays a role in health. And we also have a population here that's quite poor, and there's a lot of minorities and mentally ill and addicted that do not get the proper health care. So like, for example, RVA, Veterans Association is a national organization which has hospitals all over the country. We're one of the sickest VAs, because our veterans are poor, very poor, poorer than the national average. And Buffalo is just an impoverished city with a lot of, segregation and a lot of, there's a lot of disparities in health. Many of my patients are illiterate, which is shocking to me still that exists, but it does. I often will ask them to sign a paper, and they push it aside, and they'll kind of like, and I can kind of just read the room. And, well, would you like me to read this to you? And they'll be like, yes, can you read it to me? And then we do that, and we read it to them, and it's pretty obvious that they don't know how to read. And I've even asked people, have you ever learned how, do you struggle with this, writing? And they'll be like, yeah, they've admitted that they've never learned how to read. So if you haven't learned how to read, how are you going to get cancer screening? Or if you're addicted to drugs or mentally ill, how are you going to get your cancer screening? I mean, they're going to be chain smoking. They're going to be, having interpersonal family disputes and all kinds of issues. So the majority of the patients I see, a lot of them are quite poor and quite in a bad way, as far as I see the richest of the rich, where I get donors, that are giving me millions of dollars to build buildings at Roswell, and endowing me as a chair. So I see these people, and then the same day I'll see someone who lives in an SRO with cockroaches, and that's just kind of like how it is here. There's a lot of, I think, economic diversity, right? And because of that, I think Buffalo, that's a long-winded way of saying, yes, I think that Buffalo, I can't quote you the numbers right now off the top of my head, but I can tell you that Buffalo is a city where people do face cancer at a high rate.
There also, I think I just read that cancer's on the rise among young people right now.
It is.
Yeah.
And we see a lot of folks that are AYA, which is the adolescent young adult population. We call it AYA, which is 39 and under. And I see many, many unfortunate patients that are in their 30s and 40s, sometimes 20s, who have cancer. Many of them, it's just strange, they have like colon, that's metastatic, which is used to be a disease of, older folks. And now we're seeing that in younger people. And so there's a whole push for screening, colonoscopies, make sure you get those. Cancer screening, mammograms, but sometimes I'll see folks that just had a mammogram, last fall, and then they present with disease. And so, it's not fail safe, but, we do see all sorts of presentations.
I think it's wonderful that you have the faith as part of the palliative care package. Because I'm thinking of people, it must be, I wonder what it's like for people who don't have a strong faith of their own or a sense of spirituality, and how, I can't imagine facing death without that. It's just absolutely so foreign to me. So I'm sort of curious as to, I'm delighted to hear that you've got it. I think, at least in my family, I have been with two members of my family who have died, and they both, right before they died, said, you know what, this is okay. I know exactly where I'm going. And my grandmother said, it's okay. The Lord's calling me and it's going to be okay. So I don't want everybody to get excited, She said that, and she said, and I won't come back and haunt you. But, that is, and we've always been very practical about death in our, we say, when you die, can I have this? Or when you die, we've always talked like that about it. But I sort of wonder when people tell me that they just don't have any.
It's bad, Saxon, it's bad. It's bad. It's really hard. It's bad. When someone has no faith at all.
I'm really nervous.
So I do see people have no faith. They're completely untethered. And they may not even have any spirituality whatsoever. So I do try to find out what is it that it wakes them up in the morning? What is it that gives them purpose? And that we could say is their spirituality, whether it's I love my grandchild, or it's usually love for their family member, or something like their vocation, their job. I had a financial planner, who was still working just a couple weeks ago, right up until, he was on home hospice. He was working. And he had like a nephrostomy tube in, and he was still going to work full time. And he was like, in his 80s. And I'm like, what the heck? I said, he just loved his job so much. And on his deathbed, literally in his home hospice bed, he was doing work on his laptop and like signing off his financial advising stuff to his friends. And I was like, can I be you when I grow up? So for that, he belonged to the chapel. He was a very spiritual man, and he was not ready to go. Like he was fighting that death. He did not want. But then when it was completely non-disputable, like he was in bad shape, there was no getting out of it, and he couldn't walk anymore. So he agreed to have hospice, and we went home, and he was still on my laptop.
So a lot of times when people are planning what they want at the end, they decide whether or not they want hydration. And I've heard different arguments about whether dehydration is actually a natural analgesic, or people don't want to be that uncomfortable. Do you have an opinion about that?
I have a lot to say about that.
Okay.
I used to give the lecture on artificial hydration and nutrition for our fellows. And it was an hour long on that, with all kinds of cases and case studies in legal. And so, this is a whole hot topic, as far as artificial feeding, artificial hydration. And so I always go back to, because what's the natural process of, if we didn't have these IVs here, what would happen when someone dies? And how did God make that happen? So there's a reason why at the end of life, the eating and drinking slows down. The body is naturally shutting down. The kidneys are shutting down. So what happens when we put IV fluids or artificial hydration in a body that's dying? What happens? So I think the assumption is, when you don't know a lot about medicine, the assumption is that dehydration is uncomfortable and it can lead to suffering. When you're a healthy person and you're dehydrated, your mouth gets dry, you're thirsty, you want to be hydrated, and that's no fun if you're dehydrated. But when you're a dying person, I've asked many people what it feels like, what does it feel like when you feel this lousy, when you're weak and you're tired and your body's kind of shutting down. And people near the end of life have been interviewed when they're still able to give their advice about what's happening to them. And there was a study done, and people were asked, are you hungry? Are you thirsty? And the patients all said uniformly that they were not hungry. So the hunger usually shuts off. If the hunger is still on, then eat. But when people are close to the end, they're not alert, okay? So when someone is hours or days prior to death, they're not eating, because you don't eat and die at the same time, I tell people. And if you are feeding someone through a tube, that will prolong the dying process, and it may lead to a more uncomfortable death, because the dying body doesn't know how to handle artificial stuff. And that's the answer I usually give, is that when does fluids cause more harm, and when does it help? Generally, when someone comes in with a pneumonia and their goal is to get better, go home and live for like another year, yeah, hydrate this person, you want to hydrate them. But at the very end, if you hydrate someone when the kidneys are shutting down, the body's shutting down, what happens is the blood vessels, how detailed do you want me to get about this? It does not know how to handle the fluid, and what happens is the fluid leaks out into the tissues. It leaks out into the lungs, it leaks out into the legs, and you get, like, basically picture a Michelin Man, It's swelling in the legs, gurgling, so we call it a wet death. It's not pretty, it can lead to more suffering. So when someone's clearly dying, we do not recommend IV fluids. It will cause more symptoms that we then have to palliate, like gurgling, it may cause trouble breathing, it might cause what we call edema in the lungs, or fluid in the lungs, and fluid in the legs, which can be painful and uncomfortable. So when we don't give fluids, will that hasten death? And I always tell people that if you're dying of your disease. You're not dying from the morphine I gave you, and you're not dying for the lack of fluid. The lack of fluid is what goes along with a natural death. And when the people were interviewed about, are you hungry or thirsty, they did say they felt sometimes thirsty. And if they felt thirsty, you can have them drink. But if they couldn't drink because they were too sleepy, because before we die, we're generally less alert, and swallowing can become difficult. If swallowing is difficult, we have these things called swabs. We can swab the mouth. You dip it in a little, I'm sure you've seen it, on the bedside. You dip it in the mouth and you wet the whistle. And when I have an anxious wife who has fed her sick spouse food every time he gets sick, and that's how she loves, instead of the spoon, I give her the swab in her hand. So she can still do something, because she wants to keep doing something. She wants to keep nourishing. So food in our culture is equal to nourishment, which is equal to love. And when we all sit around, we gather around the Thanksgiving table, food is equal to family and love. And when that isn't being given anymore, it can be perceived as I'm not nourishing or caring for or loving my loved one, because I'm not giving them this nourishment. But in the very dying body, it really will be harmful to put a lot of artificial things in it. So we generally don't do that.
I want to ask this question. When my mother was dying, her body was shutting down. She was 90. She'd been on rheumatoid arthritis medicine for a number of years, and it really had taken its toll on her organs. But by the time I got to the hospital, they had her on morphine, and she really was not able to talk. And I've always regretted that I didn't have to say, my sister went along with that, and I was not in the area, and I had to come home. But I've always regretted that happened. And is it because when your body's shutting down, there's a lot of pain, and you do that automatically? Or was that, I've always thought it was just unnecessary, that she probably would have liked to. I know she could hear me, because she would react, her eyes blinked, and she would moan and talk, because I sat with her, I was the last person with her, telling her it was fine to die.
Yeah.
But I always thought, really, Mom, I just wished you weren't on all this stuff.
So I can't speak, so I can't speak for those doctors and what they did and why they treated your mom with morphine, but I can speak for how I practice and how my colleagues are trained to practice. So when you're doing it correctly, you only give a medication for a symptom, okay? So I would never give morphine to someone just because they're dying. We're trained to use our eyes and to assess a patient at the end of life. So we give morphine for a couple of reasons. Or it's not only morphine. Actually, I don't really love morphine, because it can accumulate in renal toxicity. When you have renal failure, it can accumulate, and it causes people to be twitchy, and it's got side effects. So a lot of times I'll use Dilaudid or a different medicine that's a little cleaner in the system. But morphine is that one that has the stigma that everybody gets, and at hospice, it's cheap, really, is the reason why hospice uses it. Morphine is given, it should be given if the person is having pain, but they may not be able to tell you they're having pain if they're confused or sedated because of the disease. So we're trained to look at the facial expressions and, are they grimacing? Are they moaning? Are they pulling at something? Are they breathing fast? Are they short of breath? Your mom said, I don't want to gasp for air. We actually use opioids to treat shortness of breath. We call that dyspnea. So if someone's doing this, okay, we give opioids for that because opioids switch off the sensation of feeling short of breath in the brain. Opioids are the mainstay of treatment for dyspnea, which is the medical term for shortness of breath. So was your mother having any of those symptoms? I don't know. You don't just give morphine for no reason. You don't just give it for no reason.
No, I asked that, and I think, that just always has bothered me, but it's, it's much too late now, obviously, but it's just always bothered me that she was not, because she was lucid and fine the day before I left town, and it was just, just all of a sudden, it had been starting, and actually the women that we had who stayed with my mother, she had round-the-clock care because she'd gotten to the point where she couldn't hold stuff with her hands. So, but in her own home.
So a lot of times, if a family is absent at the time of the death and something's transpired, they may come in and question what we're doing, or they may be angry or something. As a physician, I'm very kind of cautious that anytime I start a medication like that, that could be questioned, I talk to the families about why I'm starting that and is it okay to start that. So I think that a good physician, I'm not saying that physicians were bad, but I'm thinking whoever's taking care of that patient, the ideal thing is to be like, Saxon, hey, your mom is having this symptom, and I think we are going to start this medication, and this is my goal and my intent. My intent is not to end a life. My intent is not to hasten things. Generally, when people are at the very end, they may be a little bit confused or restless. They may reach into the air. They may be moaning. They may be kind of yelling out. They could climb out of the chair or the bed. So some of that might have been starting with her. Who knows? And if that happened, sometimes they'll use morphine to kind of calm some down. They'll use morphine for pain, any type of perceived pain, and it's subjective. So a nurse might perceive the person's having pain, and the doctor ordered it as needed, and they gave it.
No, and it was, 15 years ago, and 15 years, a lot of things have happened too, so.
Right. Nowadays, I'm actually a proponent of not medicating, especially in the elderly, because all medications we give have side effects. And so I'd rather just see how people do without medication first. But many times they don't do well without medication and they're having a symptom. And so when I offer the treatment, I usually say, this is what I'm offering for this. Here's what the potential side effects are. And here's what I hope and intend to happen. Here's what might happen as a result when we start this medication. And most of the time, if you withhold the medicine, they still lose consciousness right before they die. So generally, people off morphine do not die alert. It's not like the TV. So when people the 1 minute they're talking, they're saying goodbye, and the next minute they close their eyes and they're dead. That is not how it happens, okay? Thousands of people I've seen die. Unless you fall over from a heart attack, okay? If you fall over from a heart attack or a stroke very suddenly, which is rare, chronic illness usually kills people. And if you have dementia, it's usually infections, okay? You don't die of dementia. You die of infections. So, how does that happen? How does that look? And it's usually chronic, and delirium that I talked about is really common. So oftentimes people are confused and restless, and we do have to medicate them, or they're in pain. And so I'm usually not trying to give medication, but at the end of the day, we may have to do that. And then we talk to the people about why we're giving it.
Kind of a comment. A number of years ago, my in-laws, they died in the house, each at a different time. But when my father-in-law died first, and my husband and I came up, we lived in New Jersey at the time, and so we were there. And we saw him go through this process and eventually die. Only after he died did the nurse, that was the hospice nurse, come and give us a booklet on the things to expect when the person is going to die, like the lack of appetite. My mother-in-law was going crazy because he wouldn't eat.
Yeah.
And he wouldn't drink. And,
Yeah.
you know, all he wanted to, he just one day said, yeah, I'm not getting out of bed. And he just didn't get out of bed again. But nobody, and they had nurses several times a week or every day coming into the house. Nobody
That's
said,
unfortunate.
these are the things that you can expect
Yeah.
when he's going to go.
That's really unfortunate that that happened to you.
And this was.
That's not ideal.
That
Yeah.
was a number of years ago, but I have a neighbor whose husband had cancer. He was actually seen at Roswell. And she ended up having him home, and he died there. But it wasn't until after he died, she says, oh my God, he exhibited so many of these signs. And she didn't know, because nobody had told her what to expect. So.
I'm really sorry that
how do we
happened.
fix things like that?
Yeah, that's kind of what I do for a living. Yeah, I tell people what to expect every day of my life. So what I'm talking about with you right now, I literally have this conversation probably 8 times a day. So when you say nobody, it hurts me. Like, it hurts my heart to hear that people are dying and they are ignorant to what's going on around them, and they could have had some support. And even with hospice in place, that just, it's inconceivable to me that hospice couldn't do that, because that's what they are there to do. So I get kind of like a little fired up and a little bit angry actually to hear that, but I can tell you that's usually the minority. I think that most of the time you're gonna have a really excellent, I would say when people tell me about hospice, it's usually very glowing and very positive. Once in a while though, I do hear negative, just like anything else. You have good doctors, good hospice teams, good, bad hospice teams. So it sounds to me like,
Every industry.
right, like I don't think it's perfect. It certainly is messy.
Right.
Death is not perfect. You know, you have babies coming into the world where you have things go wrong. I mean, most of the time births go off without a hitch, you know, but then you have these terrible things when, you know, and so anytime there's something big happening, it could get botched up. And even under my care, you know, I'll hear things and, you know, someone on my team or something, there'll be a complaint. And, you know, you have to just apologize and do your best. And
Well, so when a person is, I'm gonna say diagnosed as terminal, or they're recommended to have hospice care or palliative care, isn't there literature or something that they should be given?
absolutely. Yeah.
And.
Yeah, we have that
So at
literature.
least-
You know, and we talk to them. So, and also it's a asking permission how much someone wants to know, because you seem like angry because you wanted to know, or they wanted to know and they weren't told. But if I'm too heavy-handed with telling, people can get very angry because they're not ready to hear it yet. So it is a very sensitive topic that you have to get the timing right. Is the person ready to talk about this? You guys are all here and you're all ready, which is amazing. But most people are afraid of death, they're angry to talk about it, and they grieve with anger. And so I'll ask them, how much do you want to know? That's the right thing to do, is to ask them how much they want to know, and what do you want to know about? Do you want to know what to expect as time goes on? Some of them will say, I'd rather not know. La, 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 put my hand in the sand, put my head in the sand. And you start to tell them stuff, and they tell you, they shut you down. They say, I don't want you to talk about that, it scares me. But most of the time when someone's enrolling in hospice, that's like a no-brainer. You know, when you enroll someone in hospice, that should be part of the enrollment, and part of the admission there, is that you're talking about what's going to happen in the coming months or weeks or days. And yeah, basically people spend more time in the bed, less time walking around, less time eating, losing weight, you know, eating less, sleeping more. And there may be, like I talked about, delirium and pain and symptoms that we will be on top of it as soon as we can.
Hospice was wonderful. When my brother died, they had hospice. And actually, he was in the facility behind Roswell, the home that you have, that he was in there for a couple of nights, and then they sent him home because he was dying. But they were terrific. My sister-in-law said it was just wonderful, everything that they, and I was present for a few of the visits and stuff, so.
Can I ask you a very insensitive question, and it's rather crude, but
I don't think it can offend me.
How does cancer kill you? Or is it all that goes on to prolong life, and as you say, the body starts shutting down? Or is this cancer just takes over your body? Does it eat things? What does it do to the body?
Yeah.
How does it become fatal?
Yeah, so cancer actually is really complex. You know, it's cells that divide rapidly, and so the tumors that you may see like on the scans or even coming out of people's skin or body, those tumors are cells that, because of a genetic mutation, they multiply too fast, and so they grow rapidly, and they don't have any discrimination about boundaries. They will just grow. So normally, you know, we don't have big growths coming out of our body causing bleeding and things like that. You might have that from cancer because it doesn't care if there's a blood vessel there, it just grows. So it's out of control growth at a very rapid rate, and then it goes into the lymph, I feel like I'm gonna scare you guys. It goes into the lymph nodes, it goes into the bloodstream, and it can spread, you know, and when it spreads around, it implants in different areas. So people don't die like uniformly all the same way. Like if you have lung cancer, you could have an issue with the lungs that comes up. People a lot of times get blood clots because when you have cancer, your blood clots more easily. So people can pass away suddenly from what they call a pulmonary embolism, which is a blood clot in the lungs. So that's a really common way people go from cancer. Another real common way is that cancer secretes chemicals in the bloodstream called cytokines. Those are disruptive to our health in many ways. They shut down the appetite, and those cytokines make us feel like we have a bad flu. So picture how you felt the worst when you have COVID or the bad flu. You just want to lay in the bed, you have chills and you're achy. Well, cancer actually secretes chemicals that make you feel that way. And I don't know if anyone's had cancer in the room, but people generally report when they have bad cancer that they feel like really just ill, malaise, tiredness, fatigue. And so often when I'm meeting people and I'm asking them about their symptoms, I'm going to ask them, you know, are you extremely tired? Are you weak? Do you don't feel like eating? Pancreatic. People end up getting bowel obstructions from bowel cancers or pancreatic. So pancreatic, it blocks your pancreas, okay? So you develop diabetes. So there's a lot of things that happen to people depending on where it is in the body. So if it's in the pancreas, you have a certain sequela of symptoms that I'm really very good at palliating. I had all pancreatic today, and I can tell you it's a challenging disease to manage. But once you get on top of it, you know, we can really get them comfy. But they get bloated because their food is not digesting. Pancreas' job is to digest food. If you have a mass in your pancreas, you're going to develop diabetes, and you're not going to be able to secrete the enzymes to digest food. So we give them artificial enzymes. But eventually it can block up and cause jaundice because it can block up your bile ducts. Okay, so people might die of liver failure because your bile ducts are attached to your liver. So all of this stuff is really kind of morbid to talk about. And then if you have colon cancer, you can get obstructions in your bowel, which is one of the things I did research on. I was researching malignant bowel obstruction and how to get those guts open up, because it's a terrible way to go to have your bowels literally locked down by tumor and you can't eat by mouth. So we feed people by the vein, or we give people tubes, you know, to feed them that way. So, you know, some of these diseases can get quite complicated. You know, people can have brain tumors, you know, and then there's only so much room inside your skull, you know, so you can die that way. I mean, so you're asking me, how do you die of cancer? There's a lot of ways. People can get tumors blocking up in their lungs, leading to pneumonias. So they could get pneumonias and die of that. But generally, it's like the disease just spreads. It kind of takes over. It makes us not want to eat, and it robs us of all of our calorie and our energy. And so many people become weak and frail and then lose weight. You might see them being very thin. And so that's generally more the chronic way that people would pass from cancer. So we're often giving them things to make them feel like, giving them energy, like steroids. We use a lot of Ritalin. You know what Ritalin is? It's like a psychostimulant. It wakes people up. People come to me, they're dragging. They can't even get out of bed. So we give them a little stimulant. They're like wide awake. They feel like $1 million. So sometimes it's not giving a morphine to everybody. We do a lot of different things. You know, they get depressed. We give them antidepressants. They're anxious. We give them medicine for that, for anxiety, counseling, psychotherapy. You know, so it kind of just depends on what it is and where the disease is.
I would think with the, you know, we're talking so much about the environment and the air and all that. these days. You know, and all the money that is put into cancer research, frankly, I think if we just cleaned up the air and the water, we would probably deal with a lot of this. I mean, if we put that much money into cleaning up air and water, you know, it's astounding to me that I think we probably made a lot of progress, but somehow in my mind, I don't think we've made as much progress as I think we should have made. And I don't think the dirtier our air is and the dirtier our water is. And
Certainly not helping.
yeah.
Certainly not helping.
My name's Roger.
Roger.
You've talked about some of the, sad things, but what about in the future? Is there new drugs that you've heard about or therapies that can give us real hope that things are going to be getting better?
As far as cures for cancer and things like that, yeah. I was sitting in an employee forum yesterday at Roswell, and there was a geneticist who got up and spoke about research she's doing, and some of the research that's being done at Roswell. So I'm very biased. I take care of people at the end of life who have already exhausted treatments, but many of my patients have lived for years before that. So I'm just giving you like literally an hour snapshot of end of life treatment, but there's many of my patients who 20 years ago when I started my career would have been dead in 6 months that are now living 4 or 5 years. For example, metastatic lung cancer used to be a death sentence when I started my career. Now, because of immunotherapy, you've heard of that, right? There's immune therapy, there's new targeted genetic treatments. So anytime you get diagnosed, they do a genetic assessment of the tumor. And when they take that assessment, then they can target certain drugs to target those like genetic mutations. And so the answer to your question is absolutely. I think that actually they're on fire with not curing cancer, but having cancer become a chronic illness that you live with for many, many years. Some of the cancers people live with for like 10 years, more, even when it's metastatic. Some people end up getting certain treatments, the tumors all melt away, and they're in remission. So that was unheard of when I started my career. I mean, cancer used to be literally a death sentence most of the time. Unfortunately, people still die from cancer, so it's not cured, but I would say there's a ton of hope if you get diagnosed, and if you catch it early because of screening, then the prognosis is even better.
Amy, do you think cancer's always been around?
I do.
Is it more prevalent in the last?
It has there's been books written on cancer that occurred back in, the Egyptian times. Yeah, it's always been around.
Always been around?
Oh, yes.
There just wasn't a name for it.
Yeah, it was.
In your experience, percentage-wise, how much genetics have played in a person getting cancer?
A pretty high amount. Yeah.
They what, I'm sorry.
He asked about genetics. Environment versus genetics. I said it's a very high amount because of family history. I have one family that, family history, BRCA1, which is a mutation that's very genetic, and for breast cancer, ovarian. And it's like, almost every woman in their family has cancer. So if you have a bad mutation, you almost need to, go and make some, have some prophylactic, surgery done or whatever to prevent something from happening. But, I think there is also environmental things like obesity is actually, it's not talked about, but obesity is a huge cause of cancer. And so all the fat we consume in our diet and being overweight, that actually is a huge cause for breast cancer and colon cancer. Obviously smoking, that's an obvious one. But also, some of the other, I think, habits that we have play into cancer. So they talk about that being a huge factor in America, for sure. That America has high rates of obesity. So things like colon cancer are really on the rise. And I think obesity plays a role in that.
Couple questions. First of all, when someone is nearing death and they have trouble expressing themselves, what's the best way to speak to them? Because you may totally not understand them, but I was just in a room giving unction to a patient 2 weeks ago, and he was trying so hard to tell them something, and they were all they assumed they knew what he was trying to say. And so they would say, oh, he means this. He wants you to do this and this, and he's like, and he was getting really frustrated because
Yeah.
they weren't on it, So
Why couldn't he talk? Did he have an impairment?
I think he was a little bit having a little bit of confusion, like he just couldn't express express himself. He was able to, and he wasn't able to speak much.
Could he write?
I don't think they tried that with him. I
Yeah,
don't
so
think
that's
he could.
that's kind of sad. Yeah, because honestly, if someone can't speak because they have an inability, like a trach, sometimes, or a stroke leaves them aphasic, which means you can't actually speak, or they could have damage to their brain that leads them to not actually be able to communicate, which is not fixable. Like, so someone might be like locked in, which is a terrible thing to happen to people, where they're aware, but then they can't express. So they're like,
It seems like a little bit of
yeah, so that can be like a stroke or brain damage that can cause that, and that is super frustrating for patients. And honestly, they get sometimes really, really anxious, and we have to kind of sedate people, like when they get super like they're locked in and they can't communicate. But I would say that most of the time, that's not common. Please don't get upset, but it's not common. But what I might do if someone is trying, like if they're alert and they're trying to communicate, but they're frustrated because they can't, I will ask them how they want to communicate. I'll say, do you want to write that down? Can you do that? And they'll be like, not able to do it, because if they can't speak, there's generally probably not going to be able to write either. But you try to like meet them where they're at, and I may sit by them and use the body language where I'm kind of open and coming closer to them, so I'm not afraid of it or backing away or like getting anxious by it. Like, I think that if you just accept it and kind of lean in, that's how I approach that. And you may not ever, unfortunately, be able to communicate if someone isn't able to speak to you. Sometimes they can write.
Yeah, that's kind of, I did a lot of leaning in, but I wasn't trying to interpret what, and I think he was, it was a little bit comforting that somebody wasn't trying to put words in his mouth, right,
Or you can be honest, I'm sorry, I didn't understand you. I wish I could understand you. So we often use the terms I wish, I worry, instead of saying I'm sorry, because saying I'm sorry it implies that you're at fault. So when you have bad news to give somebody about the end of their life, if you say, I'm so sorry I have this news, that can be annoying to the person hearing it. I'm sorry for your loss, I'm sorry. You're saying sorry all the time. So we're taught to say, I wish this wasn't happening, or I worry that things are getting worse. I'm concerned. So there's certain semantics. So if this person is like, you could be like, I wish I could understand you. Unfortunately, I'm not able to understand you, but I want to sit here with you and be with you. And you just sitting with them, and they may kind of just be like, but that sigh is kind of just them accepting that's where I'm at. I can't communicate anymore, and that's broken, and I'm going to accept that.
Yeah. The second thing is, can you tell us a little bit, I keep hearing about this MOLST form.
Yeah, I brought some. Yeah.
Yeah.
Let's do it. So the MOLST, there's a lot of things I have to talk about today. If you don't have one of these, this is a no-brainer. It's called a healthcare proxy. If you have an attorney, your attorney does a living will with you. A healthcare proxy is built into a living will. A living will is done by an attorney. No offense to attorneys, but they are not doctors who provide end-of-life care. So living wills give on paper, in writing, a sentiment, but living wills do not decide what happens to a dying person's body. So if someone says, I don't want to suffer at that, if I have a terminal condition, I would rather go peacefully and not suffer. That's what a lot of living wills say. So if I see a living will, I say, ooh, thank you so much. I now have a piece of paper that me and your family can use because you put this in writing. What did this mean to you? And then I have a discussion with them about what do they understand about their cancer? How much do they want to know about their disease? Then I tell them what to expect. And then we talk about how they want that to go, just similarly to what I did with you just now. And I also use this thing called a share tool. And there's many forms of these types of instruments, which are asking the patient and family open-ended questions about their values. It asks them, how much information do you want to know about your cancer? What are your preferences for how decisions in medical care are made? What are your preferences for the role you want your family to play in your decisions? Would you want to know your prognosis? Some people don't, actually. And a lot of people do. And we're taught, I had to train almost over 300 people at Roswell how to break bad news and do that in a compassionate way in a course called Vital Talk, which teaches them to ask, how much do you want to know? And would you want to know your estimated prognosis? And if they say, yes, I do, tell me. I know I'm getting sicker. I want to know, how to break that news to someone in a compassionate way that you're not like shattering their hope. You want to do that. Like, I wish I had better news, but I worry the time could be running short, and we should make some plans in case of the worst. I'm going to hope and pray that you have as long of time on this earth as possible, and I'm going to be your cheerleader. But in case things don't work out that way, how are we going to plan in case of the worst? And I give them this homework to fill out. So they take this home with their loved ones. They fill it out. They bring it back. Or if they know, I talked to Dr. Case about a year ago, and she said all this stuff, and I know what I want, and I want to fill some stuff out. If they're ready to fill it out, I'll fill it out on the first visit. Sometimes, most of the time, they're not ready to fill it out or even talk about it, and they're like, la, go away, don't talk about it, I'm scared. And I use a lot of humor in my practice, a lot of humor. And a lot of times people come to me, deer in headlights, scared. And by the time we're done, we're laughing, hugging, joking around, and everything's lighter. And so that's the magic of what we do. Healthcare proxy is the person that you assign when you have the ability to make your own decisions. You assign someone ahead of time that if you lose the ability to make your own decisions at any point in time, having a stroke, having a heart attack, you may not be able to make your own decisions. So you say, this is who I want to make my decisions. If you do not have one of these, it defaults to your legal spouse. Many people aren't even married to their spouse, you might find out. Like, I know plenty of people who are not actually legally married. And if you're not, guess what? It falls to all your children. And if you have 6 of them, they're all going to be fighting. So fill one of these out. Do us all a favor. Because it is not fun to try to figure out what to do for grandma when grandma hasn't elected a surrogate decision maker. This is a legal document, but anybody can fill this out. All you need are 2 witnesses. So I could hand these out today. You could all fill these out. Who has one of these? Raise your hand. Yay. Oh, look, we got a lot. Oh, that's great.
I do have a question, though.
Yeah.
We do, both of us have them. Where should they be kept on file?
So at the hospital where you're receiving treatment, like so in the Roswell system, for example, I want to scan one of these in. So I usually want my primary doctor to have a copy. You're going to want the original in your home, in a safe place where your loved ones, you're going to want your loved ones who are going to be the ones calling 911 to know where that is, okay? And the MOLST form is similar. So the MOLST form, what does MOLST stand for? It stands for Medical Orders for Life-Sustaining Treatment. It's a big mouthful. MOLST is what we call it. Have you heard of a DNR? This is basically when someone says to me, Dr. Case, let me go naturally, don't resuscitate me, don't put me on a machine. At the end of my life, I'd rather avoid machines. We will do all kinds of things to you in the American system. The default is machines, tubes, feeding tubes, fluids, you name it, we'll do it. We'll stick needles in you, and we will keep torturing people, even on their very last hours of life. We will keep doing this. Even if I'll come in and be like, Uncle, this person didn't want this. It's like pulling teeth, unless you have it documented, it will keep going, okay? And so it's very important that someone who may have a year or less of life generally really needs one of these. And how do you know if you have a year or less of life? Sometimes you don't know. But if you're diagnosed with cancer, you very well could live years, and they may not want to do that yet. But every time I meet somebody, I talk about this with them, about what it is and when to fill it out. And so as people get sicker, this becomes more relevant. Because most healthy people want to take a stab at, if I get a pneumonia, of course, yeah, I'll take a stint on a ventilator because I want to see if I can survive and live another 10 years. Because pneumonia is a treatable, curable illness, right? And you may need a ventilator for severe pneumonias. If it doesn't offend somebody to go on a ventilator, then I say go for it. But if you're an MS patient or a stroke patient and you're living a pretty tough life and you've had your 6th pneumonia, that person's perspective may be a little different than someone who's 38 and has 3 kids and gets a pneumonia because they had a bad run of COVID or something like that. So it's all a matter of the perspective. Someone might say, I don't want to treat that next pneumonia because that would be a blessing. You know what? If I get pneumonia, I'll just be home. I'll be comfortable because my metastatic cancer is going to get me anyway, and I don't want to keep prolonging this. I'm in pain and whatever, how you say it. And so we give people the opportunity to know they need to know first. In order to complete this, you need to know your own situation because it's very hard to make life or death decisions if you don't know this. So I often will start these discussions with, how much do you know? How much do you want to know? And then when I tell you the time could be running short, then we'll fill one of these out. If you have heart disease or COPD or cancer, but you're going to live 10 years, You still may want to fill out a DNR, or even someone who's healthy may say, if my heart stops, I don't want to be put through that. I'm 82 years old. I've lived a good life. Because I'll give you some statistics. Healthy people, what is the success rate of CPR in a healthy adult? Do we know this? Anyone want to guess?
20%.
So it's 15%. And then out of the 15% that survive a heart stopping in a code, which you've all seen that on TV, right? You're shocking into it. Many people die, right? So 15%, and a lot of them die. But then the ones that survive that, only 8% of those go on to get discharged if they're in a hospital. Okay? And then out of those patients, many of them have a cognitive or a disability that is lifelong forever. So they don't ever come out of that to any baseline level of good quality of life. So if somebody has advanced illness but aren't quite dying, I might kind of ask them to think about a few scenarios. If you found yourself down on the ground with a heart attack, we could attempt to bring you back, and that might be a 15% chance of survival. But in people who are elderly, it goes down to a survival of 5% or less of CPR. And if you have metastatic cancer, 2% survive CPR. People at the very end of life, it's probably almost zero. So I can certainly put you through one of these things if that's what you want. We'll code anybody. We will do that. It is not pretty. I've coded people who shouldn't have been coded. I've done it myself. But, generally we don't do that. If we have a good conversation ahead of time, we can prevent it in just about anyone. I've had 30-year-old people with 5-year-old children who opt to die at home with hospice and a DNR. 30-year-old people. So for someone to tell me that I'm 30 years old, so I want to live forever, you're not going to live forever. You have metastatic Ewing sarcoma that's gone to your liver, and you have liver failure, and you have jaundice, and unfortunately, time is short. So that person was fighting me for a good 8 months, did not want to talk about it, was using drugs to escape his pain, and we gave him that hug, and we kept with it, and he was angry and lashing out at everyone, and we worked through it with him. By the end, he was zip-lining, so we got his pain control. We got him off the illicit drugs, got him on a healthy drug regimen. He was zip-lining with his kids. He accepted us helping him because he was pushing everyone away before that. And he eventually, when he did go into the final phases, he died home with hospice. So he was 30 years old. So age has nothing to do with it. It's really just the health of your own self. And so this form, basically, it's a box checking type of situation where you check a box. Do I want to be resuscitated? Yes or no? And there's a few other things on here. What I want, full treatment with like antibiotics and fluids and feeding tubes. And so most of the time I don't ask, do you want a feeding tube? It's more of, we have a discussion and then I make a recommendation based on what I think this person will be good for them, okay? And
Are you giving us one of those tonight?
so you don't fill these out. Your physician fills it out. And I'm happy if anyone wants to fill out a MOLST with me right now. I would have to sit and talk with you a second, but I could do it quickly, and we could fill one out. If someone said, I want to be a DNR, I don't ever want to be resuscitated in any instance at all.
What I'll give it to you on Sunday at church.
So it's filled out by a physician because it needs a physician's license and it needs 2 witnesses. So people try to fill these out because they're incorrectly given these by their doctors to say, here, fill one out. It's not really meant for a patient to fill out themselves, but if they do, they often kind of botch it up and I have to redo it anyway, but it's generally a form that can be filled out together. So does anyone want to do one of these? I'm happy to do it with you. But it's best to do it with a doctor that it's not really relevant for a healthy person because in general, healthy people who have no medical issues kind of want full aggressive treatment. And then if they do have something happen, the most important thing is that your proxy knows your wishes because then they can come in and make decisions on your behalf.
We also put our daughters on our proxies for decision-making because I think if something happens to me and it's just, and they're gonna ask Jim, honestly, Jim's gonna fall apart. So I said, sure, he resented my saying that, but I know that that's going to happen. So, you know, I said, just be sure you put the girls on, especially Saxon, because she's like, you know, she's really very focused on stuff,
That's
so.
why I have a 1-800 number.
Roger was afraid to put anybody on.
There's a lot of people who won't fill these out because they feel like if they're filling things out, it's like somehow like bad karma. And, you know, I have patients that will not fill one out. And that's okay. Like, you don't have to fill this out. You don't have to do anything. Honestly, I am here to meet you where you're at. If you say, Amy, go to heck, you know, I don't want us to use the HE double hockey.
Time for palliative stuff.
But at the end of the day, if there's any time ever that you have a concern about yourself or a family member, even if it's not a cancer patient that's kind of sick or having an issue, call me anytime.
It's been terrific, this has been a really.
Yeah, thank you. And I have also these, which are kind of like, you know, these are our brochures, I guess you'd say, about healthcare planning. And when should you do it? And it kind of goes through. So if you want these, I'm going to leave them here if you want to take one. And I'm going to, for those of you who don't have a proxy, I'm happy to fill one of these out with you and be a witness. You just need 2 witnesses. It can be anyone. It doesn't have to be me. And then you fill things out like, you know, first and last name, the phone number, and then whether or not you're an organ donor, which is just a question. And then you sign it and you put your address and then it's done. And then you keep it you can keep it in a safe place. You want to do one?
No, I need to get up and get exercise.
Oh, okay. Pass them around. And then this is the share tool. Pass these around with it. Pass these around with it, because that share tool is actually quite valuable in starting, we call it the conversation, like starting the conversation about what our values and goals are.
New York State passed a law or passed a policy or something that everybody was gonna be a donor, organ donor, unless you specified otherwise. I thought that was about.
No.
It's on my driver's license.
I don't believe that they'll do it, they still need consent. They won't do it without, but I think that they heavily ask if somebody has like a brain death, they will, you know, come at you with, you know, the units, especially in a healthy, a young person who dies.
I thought that they passed a policy saying that, so I thought, okay, I don't have to.
No, I mean, it asks here if, you know,
Yeah.
you want to give any particular organs or, and even if you have cancer, you know, you can still donate anything. Like, people use corneas. I mean, this is getting super morbid, but even if you have like a diseased organ, you can still give skin, corneas, all kinds of things that they can still use.
Thorax, had somebody took a thorax out of somebody. Oh my. I mean, everything can be done, yeah.
But I do think having faith is actually a really important thing to get through.
Absolutely, and extreme unction, which is basically last rites, is I think as important as well, because that's right at the edge